Hi, my name is Christopher Voscopoulos, and this particular talk is on updates in pulmonary embolism diagnosis and treatment. So, originally, this talk was created for one of the hospitals that I work at, which is Lawrence General Hospital in Massachusetts. And Lawrence General Hospital is a smaller community hospital that does have interventional radiology services, and so IR guided embolectomy treatments are available, but we don't have cardiothoracic surgery. So, like most hospitals or most community hospitals in the United States, this talk will be mostly geared towards you, though I do think that everyone can get something out of it. So, the objectives of the talk will be I will present the updates in the diagnosis of pulmonary embolism as well as treatments. And then I'll talk about what is happening at larger academic centers in which they are creating what's all called PERTs, which are pulmonary embolism response teams, and what that would look like, specifically what their roles are. And a large part of their roles really would be the immediate assessment of patients with the use of echocardiography to look at the right ventricle, as well as lower extremity DVT assessment. And we'll also talk about some of the assessment tools that are available to help you make some decisions in terms of where to, do patients fit in terms of the algorithms of treatments that I'll talk about. So, PE really can present with features that range from no symptoms to shock or sudden death. Now, I mention that because most of us are familiar that PE can present with shock, and we think about that because those are usually the times that we're most concerned about these patients because we're having to consider possible thrombolysis or immediate trips to the operating room or the IR suite for some life-saving treatments. But the no symptoms presentation can be up to one-third of individuals, as we'll discuss. And so that's an important consideration. Now, if someone is symptomatic, they're most likely to present with dyspnea, and we'll review some of the other physical findings that they can present with. But before I jump into some of the echocardiography assessments, some of the assessment tools to use, some of this might maybe be intimidating. It might be a lot of information. Maybe it could take you a little while to incorporate into your practice. And what I want to stress to you is that here I present a huge meta-analysis, 25,000 patients, 19 studies, and they found that clinical impression alone had a sensitivity of 85% to pick up PE. So that really reassures you that if this is not prime time for you to start incorporating some of these things into your practice, don't worry about it. Go with your gut. Your gut's very good. Specifically, we can put a number on it. It's 85% good. So, in terms of what some of the physical clinical presentation symptoms are, there was a large study called the Prospective Investigation of Pulmonary Embolism Diagnosis. And as I mentioned, the most common presenting symptom is going to be dyspnea, found in about 73% of patients. However, pleuritic chest pain was the second most common, but the other one I want to mention here is calf or thigh swelling, which is found in 44% of patients. Now, of course, this is a prelude to DVT, and that's what an individual likely has in their lower extremity. And that's important because I'll present some information to show you that individuals with DVT assessment, approximately one-third of them have a asymptomatic pulmonary embolism. So it's important to keep in mind. Now, something that perhaps maybe is less common to the understanding of many individuals is that syncope can be the initial presentation in up to 10%. And I have to admit that earlier in my career, when I had the workup of a syncope patient, I didn't necessarily include always pulmonary embolism. Now, what do we think is the pathophysiology here? Well, we think it's the pathophysiology is that an individual has a DVT in their lower extremity, and then that clot goes to the heart. And when it goes to the heart, it hits the endocardium somewhere and it causes an arrhythmia. And it's the arrhythmia then that temporarily causes either pre-syncope or syncope in that individual. So take home point, the next time you have a syncope patient, do keep this in mind. Pulmonary embolism should be within your differential diagnosis. So now, again, to hammer this home, because I think that this is an important point here. So importantly, symptoms may be mild or absent, and even in large pulmonary embolism. And as I mentioned already, but here's the paper, in one systematic review of 28 studies, found that among over 5,000 patients who had a deep venous thrombosis, one-third also had an asymptomatic pulmonary embolism. So now pulmonary embolism is stratified into three particular categories. Massive, and what we define massive is someone is symptomatic with hypotension and shock. Submassive, and usually what we mean by submassive is that the individual does not have hypotension, but they do have evidence of right ventricular strain on echocardiography. And so that's going to necessitate the need for some type of assessment of the right heart. And we're going to talk more about what those echocardiography findings are. And then low risk, someone who's maybe asymptomatic, doesn't have any right heart strain on echocardiography, etc. Now, because individuals can present with hemodynamic instability, one of the initial treatments that you are going to undertake is volume resuscitation. However, I'm going to talk in a short period of time that the volume resuscitation needs to take place under echocardiography guidance. Otherwise, you run the risk of putting someone into worsened right heart failure because you overstretch the right ventricle. So before I jump into some of the echocardiography findings, if you happen to have a patient, say, in the intensive care unit and they have a central line placed and you're monitoring central venous pressure, a bump up in the central venous pressure could be an initial sign of right heart strain in these individuals. And it's important to know that it's not necessarily the size of the pulmonary embolism causing the obstructive shock. It's also that particular individual and what their comorbidities are, specifically if the individual has pulmonary hypertension already. So if someone has pulmonary hypertension already and their right heart is used to being under strain, they don't require a large PE. They could have, frankly, a very small PE, and that could just be enough to tip them over. So keep that in mind. So often in the workup, these patients is we're going to get a ABG. Now, many individuals possibly rule out pulmonary embolism if the ABG is normal. But here it's important to note that in up to 18% of patients, let's just make the numbers easy, up to 1/5, 20% of patients, they could have a normal ABG. So it's really important to keep in mind that you need to put a multitude of things together to come up with your clinical assessment, not just, one thing rules out, one thing doesn't. Now, if you do get the ABG, what are some of the things you're going to look for? You're going to look for hypoxia, which is the most common thing in 74% of patients. You can have a widened AA gradient because it's a shunt. You have that blood clot going to the lung. It's blocking off a period of blood flow going to that portion of the lung, and that can't aerate. So you have a widening of your AA gradient. However, you could also have respiratory alkalosis and hypocapnia in 41% of patients. Now, the only reason why I underline this and I bold it is because many individuals tend to think of this in our asthmatic patients, where we see individuals who are struggling to breathe and they're breathing faster and they breathe down their PaCO2 and they temporarily present with this hypocapnia respiratory alkalosis picture before going into respiratory failure. However, the same pattern can take place in people with pulmonary embolism. Now, coming back to our fluids, really, what's going to be our management strategy? Well, here I'm going to argue that the management strategy should be low amounts of volume, say 250 cc's at a time, and constant reassessment of the right ventricle. Because really, the clinical picture of hypotension is obstructive shock from right ventricular failure. And so the purpose of the fluids is to see if the fluids make the right ventricle better in terms of its contractile ability and its ability to pump. As you're giving the fluid, if you see that the strain gets worse, then you want to stop with your fluid because you can worsen the picture rather quickly. But again, the only way to do that is going to be with POCUS, with bedside echocardiography assessment, because these individuals, by definition, are hypotensive. They're hemodynamically unstable. You're just simply not going to have time to send them down to the CT scan, which a CTA could show some evidence of right ventricular function, but you can't give 250 cc's and repeat your CTA. And so again, really, echocardiography, needs to be the modality of choice available for these individuals for assessment. Now, just what do I mean by hemodynamically unstable? This will be individuals with systolic blood pressures of less than 90 for 15 minutes or longer, or clear evidence of shock despite adequate resuscitation. I mean, that's the formal definition. I mean, most of us know what shock looks like. However, in addition to this, since these patients are hemodynamically stable, again, if you have the bedside lower extremity ultrasound assessment to look for a DVT and transthoracic echocardiography, you can use that to make the presumptive diagnosis of pulmonary embolism in these patients by looking for typical signs of what pulmonary embolism looks like on echocardiography, which we will talk about. And if you had that, then you can have a presumptive diagnosis of PE. Now, why is that important? Because you're going to have a short amount of time to really intervene on some of these individuals because they have a high risk of mortality, say within the first 2 hours or so. And your echocardiography assessment of these individuals could justify the use of thrombolysis and you could save a life. So more on this in just a bit. So if these individuals do require pressors, what are the pressors that we usually tend, to go to? We usually tend to go to levophed, norepinephrine first. And the reason why that is because it has a good amount of beta 1 activity. And recall that beta 1 activity is going to be the squeeze of the heart. So we're trying to support, in this particular instance, in pulmonary embolism, the right heart, have the right heart function a little better. But you also get a bit of alpha 1. And recall that alpha 1 is going to be that peripheral vasoconstriction to where you'll increase your blood pressure via that mechanism as well, and that could help. Sometimes you might see individuals use dobutamine, and the justification besides using dobutamine is that it has stronger beta 1 activity. So perhaps you can support the right heart a little more. However, one of the concerns about dobutamine, and you just have to go into it with your eyes wide open, is that you have some reasonable beta 2 activity. Now, beta 2 activity causes the opposite in the periphery, it causes splanchnic vasodilation, so you could get some hypotension. Now, normally we don't see that in individuals. We see an increase in blood pressure. And the reason why we do is because you have greater squeeze of the heart as compared to that vasodilation. But in obstructive shock in someone with PE, then some of the blood flow from the right heart might not be getting to the left. And so you might not have that increase in inotropy that you're looking for because of the obstruction. And you might have relatively unopposed splanchnic vasodilation. And so this could be a particularly bad picture for some individuals if you're not careful. So you're going to have some consideration for empiric anticoagulation. I want to talk about this in more depth, but in general, what's your initial decision tree for this? Well, you're going to assess a patient with their risk of bleeding. There is something called the box score, but it's not really ready for real time yet. I think it will be in the future, so I'll mention it on a later slide. But for the most part, we're using clinical gestalts as to what is the patient's bleeding risk or not. Then we're going to have our clinical suspicion for PE, whether or not we're using, fancy echocardiography diagnosis, or again, whether or not you're using your clinical judgment, which is, per the research, 85% sensitive. And then, most experts will propose the use of a well score to risk stratify pulmonary embolism. And we'll talk about the well score. It's a pretty simple and validated tool to use. And that could help you clinically determine how quickly you need to start anticoagulation. And I just put this in here again that, the clinical judgment's acceptable for all this again. So here's the well score. It's 7 different variables here, and it's broken up into 3 different scores, a high, a medium, and a low score here. And I'm just going to walk through just, one of these 7 criteria as an example. And that's going to be the first one here, which is physical findings suggestive of DVT, which could be unilateral leg swelling, calf or thigh tenderness. And if you had that, you get 3 points since you automatically go into the moderate probability category right here. And then based on that, we'll see here on a very soon future slide, that's how you're going to judge whether or not you're going to start anticoagulation in what particular time frame. And so again, there's a box score, not yet ready for real time, but I think very shortly, so that's why I introduced it here. And these are some of the factors that you would consider in reference to whether an individual is high risk for bleeding or not, their age, whether or not they have metastatic cancer, renal failure, liver failure, thrombocytopenia, whether or not they're on antiplatelet therapy and what type of antiplatelet therapy, recent surgeries, head trauma. Most of these things are known to us. And if a box score becomes real time in the future, it basically would be broken up into low, moderate, and high risk, as you saw on the well score. So, one particular strategy here is, with that incorporation of the well score is, let's say if our patients are low risk for bleeding and we're going to decide, yeah, we can start anticoagulation on our patients, but should we? And so the well score would be a high clinical suspicion for PE. And if you had that, you're going to start anticoagulation right there and then. Now, if someone had a moderate clinical suspicion for PE, a well score between 2 and 6, then there, you have up to 4 hours to start anticoagulation. So you have to determine based, at the institution that you're practicing, whether or not you can accomplish more formal diagnostic capabilities for pulmonary embolism within a 4-hour window. If not, you should start empiric anticoagulation. However, low clinical suspicion, you have 24 hours to do the workup. So hopefully at your particular institution, even if it was at night, we have to wait, to the morning to get some imaging studies, etc. Hopefully that's enough time for you to incorporate diagnostic studies before starting empiric anticoagulation. So some, additional considerations here is that it's common that many patients with pulmonary embolism have hemoptysis, and this is simply because we're throwing a blood clot to the lungs and we're infarcting, that particular part of the lungs. Now, what a lot of individuals, might be concerned about is that, oh, they're bleeding. And so therefore, since they're showing signs of hemoptysis and bleeding, it's contraindicated to start empiric anticoagulation. And that is not the case. I mean, this is an exception kind of, you could think of maybe to a lot of the rules, and it's important for you to know about that. And then really the optimal agent for anticoagulation we'll talk about. I mean, for the most part, it is continuous heparin because it's quick on, quick off, and we could reverse it if we needed to. And it's easier then to incorporate thrombolysis in terms of its how its duration of action. However, there are certain patient populations to where we will consider things such as DOACs, direct 10A inhibitors, low molecular weight heparin, and we'll talk about that. So here I'm going to present to you two algorithms, one in a hemodynamically stable patient population, the other in a unstable hemodynamic patient population, and give you what the decision tree would look like here. And so here we have a hemodynamically stable patient, and then we ask ourselves the question, is anticoagulation contraindicated? And the answer happens to be yes. And so we then continue with our diagnostic workup, and if PE is excluded, well, then we look for other causes, for what's going on in the patient. However, if PE is confirmed, and then anticoagulation again is contraindicated, then we would place an inferior vena cava filter. Let's move over here. Hemodynamically stable, and then we're going to move here. Yes or no. If the answer is no, then we're going to move to the algorithm for hemodynamically unstable patients, which we'll talk about. Then we're going to ask ourselves here, what's our clinical suspicion for acute pulmonary embolism? And here is the well score, right? Where we break them up into low, moderate, and high, and then how much time we have to work up based upon the previous slides, whether it's 24 hours or 4 hours for moderate, or high, in which we're going to consider starting anticoagulation immediately. So let's now go down through the high pathway here and what the diagnostic evaluation looks like. So here, if we continue with our diagnostic evaluation and P is excluded, well, then we're going to discontinue our anticoagulation that we started, and then we're going to seek, of course, other causes for what's going on with the patient. However, if PE is confirmed, then we're going to ask ourselves the question is does the clinical severity warrant consideration of thrombolysis? And we'll talk more about bedside echocardiography assessment for the help in that decision. Now, the question then is going to be, if that's answered yes, then we're going to ask ourselves, is thrombolytic therapy contraindicated? And then if it's contraindicated, we're going to have to seek another mechanism of embolectomy, which is going to be surgical or catheter directed. However, if the answer is no, then we're going to go ahead with our thrombolytic therapy. We'll hold our heparin, and then we'll restart it at an appropriate time after the thrombolysis. We're going to assess for clinical improvement. And if they don't clinically improve, we can consider repeating the thrombolysis, or we'll progress them to surgical or catheter embolectomy. Of course, if they do well, we just continue with our anticoagulation. So, what about our hemodynamically unstable patients? And I hope here my picture here is not occluding some of the visual here, but I'll go over it verbally for you as well. So here we have a hemodynamically unstable patient. We do our resuscitation, and then say if we do a resuscitation and the patient now becomes hemodynamically stable, we're fine. We then actually go to the prior algorithm, which was the hemodynamically stable algorithm. However, if the patient remains hemodynamically unstable, well, that's where we have to do bedside echocardiography assessment because they're too unstable to go to the CT scanning. And we're going to look for evidence of right ventricular overload. And if we don't see that, then we can pretty much rule out at that temporary point in time, PE, and we have to look for other causes for the patient's hemodynamic instability. However, if the answer is yes, we do see evidence of right ventricular overload. Say we see things like a McConnell sign, which we'll talk about shortly. Then we need to ask ourselves the question is thrombolytic therapy contraindicated? So if it's not, of course, we're going to give it. And if it is contraindicated, then we're going to have to progress to our surgical or catheter-directed embolectomy. So, why do we treat? So we treat because in general, if left untreated, pulmonary embolism is associated with an overall mortality of up to 30% compared to 2 to 12% in those treated with anticoagulation. So what are the echocardiography, findings suggestive of acute right ventricular strain that suggest pulmonary embolism? And so what we're going to look for is, three things. We're going to look for an enlarged hypokinetic right ventricle. We're going to look for what's called the McConnell sign, and we can look for what's called the 60-60 sign. Now, for the most part, the first two things can be just pattern recognition, meaning that your eyes are good enough to look and tell whether or not the right ventricle is functioning. You don't need the fancy TAPSE, which we'll talk about, and other things. You can just quote unquote eyeball it. And the literature clearly says that that's good enough. McConnell sign, of course, will be, pattern recognition, and so you don't need any fancy measurement tools there. The only one that you do require some fancy measurement tools is 60-60, but arguably maybe you don't need that, but I will address it here briefly. So here, is a picture of what our right ventricular dilation would look like. And so normally, here's the left ventricle, and that should be bigger than here, what is the right ventricle. So the fact that the right ventricle is bigger than the left tells you right off the bat something's wrong. Something's really wrong, because this is like 2 times the size of normal. Now, the other thing what you would like to do is you'd always like to know, in addition to the dilation of the right ventricle, is how well this right ventricle contracts. Now, normally the right ventricle would contract up and down here. So here's the edge of the tricuspid valve, and this is called the tricuspid annular plane right here on this particular side. And this pumps up and down in kind of a piston fashion here. And what you could do is if you wanted to measure how well this thing is contracting here, is you can see this green line coming down here, what's called an M mode ultrasound beam. An M mode is just one beam, so not two, not three-dimensional, just one beam that goes down, and you would get this. You'd get a bumping up and down of this tricuspid annular plane, and then you could measure this. In this particular picture here, this is 28.4, and the one down here, which is possibly occluded by my picture, it's 6.3. And then you just have to know, well, what's normal? And here I'll argue and I'll say that what you're looking for is a cutoff of 17. Some places use different cutoff values for the TAPSE. 17 is roughly accurate. You can go ahead and use that. But if you see a different cutoff, that would be fine too. So what a TAPSE is simply a distance, right? It's this tricuspid, annular plane going up and down here. And again, you're just going to look at that cutoff value for less than 17 for measurement. Now, where this could possibly come in handy is that if someone has a history of right ventricular, dysfunction, and if they had a prior, known TAPSE of say, 15, and now you're doing your bedside assessment that's 15, that's where it's really helpful to come in. So you do want to record these things if you can. So on my particular website, which I just love putting this information out there because it's just something that I'm passionate about, medical education. I just enjoy doing it. I do have a video here on how to obtain a tricuspid annulus plane excursion TAPSE with one of the bedside portable ultrasounds that are used. In this particular one, the Butterfly IQ, but really you can use the Philips handheld device. The GE Vscan is a wonderful device as well. Really, any of them would probably serve your purpose. But in addition to the TAPSE, I also have how to diagnose McConnell sign and many other educational topics. So in reference to McConnell sign, here's how I'm going to describe it how I remember it here. And I'm not saying that this is necessarily correct in terms of the pathophysiology, but this is how I keep it straight in my mind. So here we're looking at, a particular pattern of right heart strain indicative of PE. And here you see the free wall of the right ventricle, which is the majority of the right ventricle. And this gets overstretched and it goes into failure. And so it starts to actually bulge out. And that's what happens with an akinetic wall in the myocardium. It bulges out. Either it bulges out or it just doesn't contract at all. But then the interesting part here is in addition to this bulging out and not contracting, this appears hyperkinetic. It appears to just bump up and down, up and down, up and down. And so I remember this is that this apex is really close to the left ventricle. And the right ventricle is in failure, and so that's why this wall is not bouncing. But since this apex is close to the left ventricle starts to, beat as hard as it can, and it gives the, impression that it's beating, part of the right ventricle apex a little bit because the left ventricle is working so hard. Again, I'm not saying that's exactly what happens. It's how I particularly remember, this particular constellation of findings. Perhaps you might find that helpful for you as well. So here then, we have the 60-60 sign, and it's composed of two particular components, a tricuspid regurgitation jet gradient of less than 60, and a pulmonary flow acceleration time of less than 60, hence the name 60-60 sign. And just in very brief, again, you can get more information about this on my website here, is you're going to get the tricuspid valve into view right here. You're going to shine a Doppler wave down here, and you're going to get your gradients, and you're going to look to see if there's less than 60. And then here, you're going to get the pulmonary valve view here, as you see here, in a parasternal short axis view. Here you can see the aortic valve, and you're just going to shift over here and get the pulmonary valve in play. Again, you shine a Doppler signal down here, and you see if it's less than 60. So again, in addition to the echocardiography assessment, you're also going to want to have a lower extremity DVT assessment. And here's just a slide for you to recall the basic anatomy. And what you're looking here is for the common femoral vein. And so really, it's very simple to do lower extremity DVT assessment because it's not practical for you to find the vein and then follow the vein all the way down to the back of the knee, the popliteal area, and then follow that vein all the way down to the ankle to see if you can see a blood clot. We don't do that. So luckily enough, there's a better way to do it, which is way quicker. And that is that you're simply going to look for, say, one particular plane. You're going to find, say, the femoral vein right here, and then you're going to look to see if it's compressible, because a vein should be compressible. And if the vein is not compressed, the reason why it's not compressing is because there's back pressure somewhere. Why is there back pressure? There's back pressure because there's a DVT. So you've diagnosed DVT based on the fact that the vein won't collapse. You might not know where that, the embolism is or that DVT is, which in the vein, you don't have to know. You're just diagnosing that there is a clot somewhere in that particular vein. And so here's just a picture, of someone finding the common femoral vein here at the level of the groin. And again, you're just going to apply pressure and you're going to see if it collapses or not. Here's another picture of finding the common femoral vein just in a slightly different, area. You're going to again see if it is collapsible or not. And then here, the same thing, you're going to find then the popliteal vein. So you find it one time up top in the groin area, one time in the back of the knee. And, it's the same particular assessment here. You find that popliteal vein and you see if it compresses. Now, some individuals, instead of, or in addition to seeing if it compresses or not, they squeeze the back of the thigh and then the back of the calf. And then squeezing the back of the calf, they see if the the popliteal vein increases in size because you're increasing blood flow. And that is, one thing that you can particularly do. I tend not to incorporate that anymore because I'm concerned of propagation of clot. But I mention it because you possibly could see that mentioned by other individuals. So here, in addition to seeing if the, vein is collapsible or not, you can just see a picture of an embolism, of a DVT, and you can see a DVT in veins. It's actually fairly common, we'll talk about, of seeing a clot actually on the right ventricle in the ICU, and I'll talk about how frequent that is shortly. So I've spoken a lot about lower extremities. However, it's important to also include upper extremities as well. So although upper extremity DVT embolizes less commonly than lower extremity DVT, symptoms of an upper extremity DVT, such as arm pain or tightness, should also raise the suspicion of PE. So please keep that in mind as well. Now, again, this particular talk was created for Lawrence General Hospital in Massachusetts, but perhaps maybe this is applicable to you as well. And so it is the consideration for the creation of what's called a PERT, which is a pulmonary embolism response team. And what would be some of the functions of those individuals that would, respond to this patient population? Well, it would be assistance with incorporation of the Wells score to determine whether or not you should start anticoagulation at that moment or not. It would be the incorporation of echocardiography for both right ventricular function as well as lower extremity DVT assessment. Of course, that'll be very important for the decision upon whether or not someone requires thrombolysis. An individual in this PERT team could also assist you with the decision algorithm in terms of where someone would go in terms of treatment. Maybe they just require a IVC filter. And because I am a critical care anesthesiologist, I wanted to mention that, say, if an individual had to go into the IR suite to get a catheter-directed embolectomy or thrombolysis or otherwise, these individuals are at a high risk of mortality and of complications. And it's my opinion that an anesthesia provider should accompany that individual to the IR suite to help prevent them from going into either some type of cardiac event or severe hypotension. Because once they go into those particular phases, it's often much harder to get them back. So I think that we should be there to try to prevent that as much as possible. So briefly, just to mention some special patient populations, if an individual has malignancy, then instead of regular heparin, we would more consider low molecular weight heparin and some of the DOACs. If an individual is pregnant, then that's when we consider our low molecular weight heparin. And if an individual has, say, heparin-induced thrombocytopenia, that's when we're going to look at our fast-acting non-heparin anticoagulants, really largely our Gatroban. So a little about shock. So again, the initial presentation of PE can present with shock in up to 8% of patients. And why this is so concerning is that it's associated with a 30 to 50% risk of death. And here, the risk of death I want to mention is greatest in the first 2 hours of presentation, which is why the rationale for the consideration of reperfusion therapy with things such as thrombolytics or embolectomy rather than anticoagulation is so important. But again, since you only have 2 hours and these patients are hemodynamically unstable, really someone has to be able to perform the bedside echocardiography assessments to make that decision upon whether or not thrombolysis is required. And though these 2 hours I mentioned as a golden window here are so important, it's also important to mention that this risk remains elevated for 72 hours or more as well. So what about post-diagnosis and treatment considerations? Well, really, you have to talk about recurrence, and the risk of recurrence, either deep venous thrombosis and PE, is really greatest in the first 2 weeks. So it's about 2% at 2 weeks and then 6% at 3 months. And certain factors that could put a patient at particularly higher risk would be things such as the history of cancer or failure to reach their therapeutic anticoagulation goals that we wanted them to. However, individuals could also present with pleuritic pain, alveolitis, or pneumonia. Now, I mention this because some individuals could infarct or partially infarct a portion of the lung. Their cilia become less apt to be able to function. They have lack of clearance with bacteria, and hence they develop pneumonia. And if they do, really what you want to do is you want to repeat the CT on these individuals because you want to compare apples to what their CT looked before as compared to what it looks like right now to be able to diagnose a pneumonia in this patient population. In addition to this, I just wanted to mention this one particular entity because some individuals might not be familiar with it, and that is thromboembolic disease and chronic thromboembolic pulmonary hypertension. Now, what this basically is an individual that, because of complications from a PE, they typically present with progressive dyspnea within 2 years of the initial event. And this is important to keep in mind because these are individuals that really are going to have to have a diagnosis or a workup, I should say, for things such as pulmonary hypertension and otherwise, and they're going to require referral to our pulmonology colleagues for more of a workup. So, what are some of the poor prognostic factors in patients diagnosed with PE? Again, I've spoken a lot about shock and right ventricular dysfunction. Um, And really, one of the take home points from this particular slide here is again, though I mentioned it, but it's just so important, is that right ventricular dysfunction is best assessed by echocardiography, even though it can be assessed a little bit by pulmonary angiography as well. And perhaps maybe one of the largest reasons why that's important is because it's not necessarily just right ventricular dysfunction. It's symptomatic right ventricular dysfunction. That's the largest predictor of mortality and complications in PE. And so it's largely felt more that the bedside echocardiography is more of a dynamic assessment of that symptomatic right ventricular ventricle as compared to really what's more arguably maybe more of a static image, which is the CTA. So RD dysfunction may also predict recurrent venous thromboembolism. And so it's important that someone does not just an initial right ventricular function assessment, but also one at a later time. And that's because here, in this one prospective observational study of 301 patients with PE, those with persistent right ventricular dysfunction on echocardiography at 3 months following diagnosis had a fourfold increase in the risk of recurrent venous thromboembolism when compared with patients without right ventricular dysfunction or patients whose right ventricular dysfunction resolved prior to discharge. And so it's again going to be important that we get that baseline. So for more likely our cardiology colleagues in the outpatient setting will have this information that'll be important to them. So can you assess right ventricular function without echocardiography? And you could. Two particular markers you can look at would be BNP and troponin. So, of course, just as these things can be elevated in left heart failure, they're elevated in right heart failure as well. At the current moment, we don't really have cutoff values, and so it's more binary. It's whether they're elevated or not. But if they're elevated, then there are going to be considered markers of right ventricular dysfunction. So, please order these in your part of your global workup of these individuals. So just a brief word here that you can see right ventricular thrombus. Now I primarily practice in the intensive care unit, and really you could see a right ventricular thrombus in up to 18% of critically ill patients, and it's something that I have seen many times. And I just wanted to mention it because it's something that you should look for. When you first see it, you'll probably end up seeing it more frequently because again, it's more common than you think. So a word here on deep vein thrombosis and why it's so important. So patients with PE and coexisting DVT are at increased risk of death. And this particular prospective study here, reported their increased risk of all-cause mortality. And so it's important that, in addition to diagnosing the PE, whether that's with CTA or echocardiography, is to also, look for a DVT as well to help risk stratify these patients. Now, here, there's something that's called the PESI, which stands for a Pulmonary Embolism Severity Index. Now, the PESI contains many, many, many variables, and arguably it's difficult to use because it has so many variables. But luckily enough, there's something called the SPESI, which is just the simplified Pulmonary Embolism Severity Index. And it's just these particular variables that you see here. So age, history of cancer, chronic pulmonary disease, etc. And basically, a score of 0 indicates a low risk for mortality, where a score of 1 or above indicates a high risk. And so this can be important for documentation in your notes, for justification of case mix index, for severity of illness, etc. So this is why you might want to consider this. Now, what are our goals for therapeutic anticoagulation? Well, if we're using our unfractionated heparin, we want to monitor our APTT, and we want to have a target range between 1.5 and 2.5 the upper limit of normal. If we're using something such as warfarin, we're going to monitor our PT with the INR, and we want a goal INR between 2 and 3 with a target of about 2.5. And then, of course, if we're going to use our low molecular weight heparin, our fondaparinux, or factor Xa and direct thrombin inhibitors, those don't require laboratory monitoring. So now there's something that's called a PERT, and that's a pulmonary embolism rule-out criteria, and it can be used to help determine whether or not you want to order your D-dimer testing, which we'll talk about on the next slide here. And this has really been more validated in the outpatient setting. So we really think, in terms of outpatient, in terms of the hospital, we think more of the emergency department. And so here we can see all these particular variables. And basically, if someone is negative for all of these variables, so age less than 50, heart less than 100, no prior DVT or PE, etc., then that will obviate the need for ordering a DVT. I'm sorry, a D-dimer laboratory value in these individuals. Now, in reference to D-dimer testing, so Here, I could talk about more complicated things, such as, age-adjusted D-dimer, but I think just for the purposes of this talk, it's more simple to keep it binomial. What I mean by that binary is that if you have a D-dimer level less than 500, then we're going to say that no further testing is required. And if an individual has a D-dimer level greater than 500, then further imaging with diagnostic imaging, such as the CTA, then is then required. So I have spoken a lot about CTA. And so how sensitive is CTA? Well, it really all depends on your clinical suspicion for PE. So an individual with a lower intermediate clinical risk groups, the CTA is about 90% sensitive and specific. However, when you move into the moderate to high probability risk groups, then the sensitivity rises to greater than 96%. Now we've spoken a lot about thrombolysis. However, what I haven't mentioned so far is really what is the typical dose of thrombolysis, and how what duration of time is it given under, etc. So we usually think of full dose thrombolysis as 100 milligrams of TPA, and it's usually given in a dose of 10 milligrams of thrombolus, and then followed by the other 90 milligrams over the course of 2 hours. So there, what that tells you is that you have two variables. You have total dose that's given, and you have total duration of time at which it's given over. However, I mean, are there maybe better dosing regimens that might be available? And this particular, original study was interesting, and this was what's called the MOPPET trial. It stood for moderate pulmonary embolism treated with thrombolysis. And there they argued that maybe perhaps a lower dose of TPA, maybe in certain select patient populations, maybe could lead to the same efficacy of treatment, but with a focus on less complications. Because, of course, we're really concerned about in giving full dose thrombolytics is the risk of bleeding and major complications from bleeding, particularly head bleeding. And so, if you can do anything to lower that risk, perhaps maybe that would be a benefit. And here they did find benefit in overall lower mortality, lower complication rates. However, this particular study was only 121 patients, but at least this started to, raise ideas. I mean, particularly what they found is a low rate of complications, actually no complications, and they found low rates of pulmonary hypertension. So an individual had pulmonary hypertension to begin with because of the obstructive shock, and then that was reversed. And so these are really, beneficial. And, this led to, further questions in this area being raised. And so now, along those lines, more studies have looked at reduced dose systemic thrombolytic therapy. And so in this next one here, this was a randomized trial of 118 patients with acute PE, two-thirds of whom had significant pulmonary obstruction and RV dysfunction, and one-third of whom were hemodynamically unstable. And they compared, again, a lower dose, half the dose, 50 milligrams of TPA, as compared to the full dose, which is the 100 again. And the low dose TPA resulted in a lower mortality rate and lower bleeding complications. In another study here, this is a retrospective database study of patients with PE undergoing thrombolysis, both hemodynamically stable and unstable, and they reported that patients treated with alteplase 50 milligrams required less vasopressor therapy and invasive ventilation, but they needed escalation of therapy more often than patients treated with full dose. And so that really raises the question then maybe if we have an individual who is in shock, then perhaps maybe 100 milligrams of treatment is better. But if we have those submassive patients that maybe that they're on, the cusp, quote unquote, say, perhaps maybe a well-informed risk first benefit, conversation, maybe perhaps the lower dose might be more effective. Now, again, I've just spoken really largely so far about the half dose, the 50 milligrams, but the other variable then is time. And so here, this was a case study of four patients who reported success of ultra low dose and slow infusion of TPA, only 25 milligrams, but 1 milligram per hour. And so what that just tells you there is that, in addition to dose, we just really don't know the amount of time to give the drug over that would be optimal, at least for certain patients. Here, I just wanted to mention this particular study. I mean, as a critical care doctor myself, I'm always passionate about being able to expand procedures into the ICU. And we've seen that over the course, of the history of our careers. Percutaneous tracheostomies, now followed by many of us with balloon-guided uh, percutaneous gastrostomy tube placements. And, in our sick patients, maybe that can't travel down to the IR suite, who are in the intensive care unit. Now, we have the option here for bedside angle catheter IVC filter placement in the intensive care unit as well. So this is something to keep in mind at your particular institution, perhaps. So I just want to thank you for your time. And really, the questions that are going to be asked is whether or not a PERT is appropriate at your institution. So I asked that question at my institution at Lawrence General Hospital. And again, what would you incorporate, in your PERT team members' abilities? So that would be the echocardiography assessment, the ultrasound of the lower extremity assessment, perhaps some of these assessment tools and assistance with decision tree algorithm. Where would patients go in terms of get the best treatment? And when to start their anticoagulation if you use things such as the well score. I also wanted to remind you that many training modules are available on my website at www.med-specialist.net. So please feel free to go there if some of the further training is of interest to you. And last, just thank you for your time and spending a little time with me in studying this topic.